Do you ever feel a sharp pain in your back when you twist or turn a certain way? Maybe you've started to notice an increasing pain in your hips when you get up in the morning. Or perhaps you've been dealing with a combination of different aches and pains all over your body for years. If any of these issues sound familiar, you won't want to miss today's show. We have surgeons who specialize in back, spine, and orthopedics, as well as pain management specialists, to share some common problems and the best treatment options available. That's coming up today on Stronger Together with Dr. Dave. Hello and welcome to Catholic Health Stronger Together with Dr. Dave. Today we're talking about common aches and pains and most importantly, how to treat them. I'm very excited for our first guest, Dr. Morgan Chen, a spine surgeon at Catholic Health. Dr. Chen, thank you for joining us.
Thanks for having me, Dave. I'm a spine surgeon. I'm the chief of orthopedic spine surgery at St. Charles Hospital. I am part of the multidisciplinary spine team based out of St. Charles and our Suffolk County hubs in Center Reach and Riverhead. I treat and see the spectrum of neck and back patients from simple strains and sprains to people who need complex revision surgery.
What are some of the most common causes of back or spinal pain?
It's funny you say that, Dave, because oftentimes in our medical literature, it's cited that greater than 90% of patients or people will have an episode of pain in their lifetime requiring medical attention. So back pain, like you said, is very, very, very common. So when a patient comes and sees me, they don't tell me what their problem is. They just say, hey doc, my back hurts. And that's when I have to figure out what I'm dealing with. Does this patient have a disc herniation? Do they have lumbar spinal stenosis? Or is it just simply a strained muscle? So some of the common things I see are disc herniations. Disc herniations are a protrusion of the cushion pad of the lumbar spine. Sometimes they'll protrude abnormally and cause some pain. Another common pathology I encounter is stenosis. Stenosis is the medical term, as you know, for narrowing. So, if you have narrowing of the lumbar spine, patients tend to have a pinching of the nerves. If their nerve is pinched, they'll get radiculopathy, or as patients call it, sciatica. And that's a condition where patients will experience arm and leg pain from a pinched nerve, and it just depends on where that nerve is coming from, the neck or the low back. So as a spine specialist, I'm always trying to figure out what's wrong with these patients, and so that I can gear them towards the right treatment.
So you're really almost like a detective.
Yeah, you could say that, yeah.
So somebody comes to your office with back pain.
Yeah.
What is the most, in your experience, what is the most common cause of back pain? And is this something that typically needs surgery or intervention, or will it resolve on its own?
So fortunately, most of these patients I see in the office who are excruciating pain will not need surgery. Most of these conditions can be treated non-operatively with either physical therapy, pain management, just some rest and some medications. But there are some conditions that ultimately do need surgery. Those can be some rather large disc herniations, some severe lumbar spinal stenosis. But the reality is most patients do not need surgical intervention and can be treated non-operatively.
So people watching, just about everybody watching this show has experienced back pain once in their life,
Sure.
Maybe more, probably more. When should they call you a spine surgeon to be checked?
I really consider myself a spine specialist, so my office is open to everybody, not just those that need surgery. I'm oftentimes the first doctor that a patient will see after they hurt their neck or back. So it's my job to hear what their complaints are. I'll oftentimes need the help of some x-rays or MRIs to help me with the diagnosis. Once those results come back, I'll correlate those findings with the patient's symptoms and pain and come to a definitive diagnosis. Once we have that, I can customize a treatment plan for them and incorporate them into our treatment team, our multidisciplinary team, whether they need physical therapy, whether they need pain management. We have a great team of physical therapists and pain management doctors here at Catholic Health. So fortunately for most patients, this debilitating pain is only temporary, and they typically do not need my surgical expertise. But as you said, there is a small percentage of patients that will fail these treatments, and ultimately at that point I will offer them surgical treatment.
How has spinal surgery evolved, and how are you bringing that to patients through Catholic Health?
That's a great question. So my area of expertise is minimally invasive spine surgery. So I use the newest technologies and hardware so that we can perform very small, complicated surgery through very small incisions, through robotic navigation and powerful microscopes, we can perform the entire procedure through typically a 1 or 2 inch incision. Now that can really benefit the patient in many ways. Number one, it's much less tissue damage, much less tissue trauma, and that ultimately can help them with much less postoperative pain, require much less postoperative narcotics, and ultimately recover quicker.
So much better for the patient.
Absolutely. Most of my patients after 2 to 4 weeks are back to work and back to the activities that they love.
Did you say 2 to 4 weeks?
2 to 4 weeks, yes.
So patients after spine surgery can be back to work and doing whatever they love between 2 and 4 weeks.
That is very
That's
possible. With minimally
unbelievable.
invasive surgery, that is possible.
You mentioned to me that you're trying to get away from fusing patients. Tell us more about that.
Dave, when I see a patient and I'm evaluating for the need for surgery, I'm always thinking of a solution that can potentially spare their motion. How can I avoid a fusion in this patient? And most of the time, we can come up with a solution for that. So in a motion-sparing procedure, the patient's back is not fused. We're not implanting rods and screws to fuse their back. Now, this benefits the patient because they can maintain their flexibility, maintain the motion in their spines, and ultimately, once they're recovered, return to the activities that they love.
Dr. Chen, thank you for joining us today, and I hope to have you back on the show.
Thank you.
Coming up next, we'll hear from a neurosurgeon who also specializes in spine surgery, who will tell us about some new procedures being offered at Catholic Health. You're watching Stronger Together with Dr. Dave.
For more than 100 years, American Humane Association has been teaching kids to be kind to animals. Those in our homes, on the farms, on the silver screen, and wildlife conservation, caring for the world's vanishing creatures. But we can't do it alone. Visit kindness100.org to find ways to teach kids how they can make a more caring, compassionate, and humane world for all of us.
Welcome back to Catholic Health, Stronger Together with Dr. Dave. Today we're meeting some Catholic Health specialists who can help with common aches and pains. My next guest is Dr. Satish Subbaiah, a Catholic Health neurosurgeon who specializes in spine issues. Dr. Subbaiah, thank you for joining us today.
Thank you for having me.
Very excited to have you on this episode because we are discussing back pain and spine issues, which you know better than anybody is very common. And a lot of our viewers have experienced these issues in their lives. Why is neurosurgery important when we talk about spinal surgery and spinal care?
Well, as neurosurgeons, treating the spine has been part of our practice, part of our training. Neurosurgeons focus about 7 years of our training after medical school on treatments of the brain and the spinal cord and the nerves. And so for 7 years, we are trained to treat those conditions, operate and treat them, clinically. For patients, or for doctors who want to do an additional year of training to subspecialize in spine, often they'll do a 1-year fellowship, and so I've done a 1-year fellowship in minimally invasive spine surgery, and that's where we focus just on spine surgery for that 1 year. And so as spine surgeons who are neurosurgeons, we've had a tremendous background of training on operating on the spinal cord, on the brain, doing delicate procedures under the microscope to treat these conditions, and so it allows us to focus on the nerves and the spinal cord treatments while also being able to treat all aspects of the spine.
So as we were discussing before, my impression when we talk about spine surgery was there's a surgeon and an anesthesiologist and his supporting team or her supporting team. But in your case, you informed me that you are working as a neurosurgeon with an orthopedic surgeon at the same time on the same patient. Yes. Tell me more about that. Why is that important to have those two perspectives?
Well, there are certain conditions in medicine, such as cardiac conditions and spine conditions, which are very, very difficult and very sensitive. And so often you'll need 2 specialists in the field. And spine surgery is one of those conditions that needs 2 specialists. Having a neurosurgeon and an orthopedic surgeon kind of provides the best of both worlds. There's the neurosurgeons who's focused on treating the spinal cord, treating the nerves, and the orthopedic surgeons who support that and helps with the bony anatomy, helps with the fixation, the fusion. And so having 2 surgeons is better for the patient and better for everyone.
And Catholic Health is doing something really special. And I think they're pushing the envelope here. They are really creating these hubs. And what's great about Catholic Health is it used to be St. Francis and Roslyn, and now it's moving to Comac, and then it's moving to Center Reach, and now and it's been at Port Jefferson, and we're even going as far as Riverhead.
Correct.
Are you guys going out there? Are you bringing spinal surgery out to people as far as Riverhead?
Yeah, one of the unique things that Catholic Health offers are these hub models for ambulatory care, and I think that's perfect for spine surgery. In these new hubs that are being built and are being built right now, you have almost like an ambulatory hospital where there's patients are able to come for their urgent care, they're able to come be treated with their physical therapy, for their pain management, as well as see the specialist, the spine surgeon, who kind of can oversee all their care in one setting where their doctors are right next to each other and they can do the physical therapy and see the specialist. It's a very unique model, and patients love it.
The biggest complaint is, well, I go here for rehab, I go here for my labs, I go here for my x-rays or my CAT scans.
Yeah.
And with these hubs, patients will start and proceed and then finish in the same hub, which typically is pretty close to their house.
Yeah, the patients, I've had patients who were able to come and able to get their MRI on the same day. They come back to see me, and then I send them straight to the pain management right then and there, because they're all right there. And then we're able to coordinate our care, to see how well they did with some procedures and injections, and then if they need more, and we're all sitting right there, and we can all coordinate the care together.
It's fantastic, and I think again that goes to the theme of Catholic Health being really what I consider a very compassionate system. And I think having a hub like that is really taking into consideration what's in the patient's best interest.
Correct. Yeah. No. It's convenient, so they don't have to go to multiple. They don't have to take time off and go to multiple visits in different locations, and it's also reassuring for them because all their doctors are in one place, and so they know that there's going to be no miscommunication, and they know that we are all communicating and directing the care together.
That's great. That's fantastic. Anything else you want to tell the viewers about Catholic Health and what you guys are doing in terms of spinal disorders?
Well, we treat patients. We treat patients' pain, and so patients sometimes think that I don't want to see a spine surgeon because I'm going to get spine surgery. And so the key thing is that about 95% of patients I see don't need spine surgery, and so they do need to have a good diagnosis, and they do need to have a coordinated treatment plan. And that's why it's important to see a specialist, because we were able to give the good diagnosis and then follow the patients as they do their physical therapy, as they do their pain management, see what's working, what's not working, and then ultimately, if they do need surgery, we're able to treat them right then and there.
And you said that 90% of patients who see you do not need surgery.
Yeah, 90 to 95% of them do not need surgery, and they need conservative treatment options.
That's fantastic. Yeah. That's really great. Yeah. So it's seeing the whole patient, taking into consideration, not just seeing the spine, but what else is causing potentially their spinal issues.
Correct. Yeah, seeing what about their lifestyle, what about what they're doing, how they're even sitting, standing, what they do at work, trying to figure out what's causing their pain, try to prevent that from happening again. But if they do need surgery, we offer the most advanced minimally invasive techniques. 85% of our patients are able to go home the same day after surgery, and all about trying to get them back into work, get them back into enjoying life as quickly as possible.
So you mentioned conservative treatments. Can you just expand on that a little bit? When you say conservative, what are we talking about?
So after the patient comes and we get a good diagnosis by finding the X-ray and MRI findings and getting a good diagnosis, conservative treatments are in two categories. One is what the patients can do with the physical therapist for stretching, strengthening, core strengthening and activity modifications to try to prevent this back pain from happening again, as well as pain management. Pain management includes medications, as well as injections, as well as procedures like where they can burn or freeze the nerve, all about trying to treat the pain non-operatively.
That's a great way to end this conversation. Okay. And I hope to have you back on the show and we can hear more about what's new and exciting in spinal surgery.
Great. Thanks for having me.
Next, I'll be joined by an orthopedic surgeon who will tell us the treatment options available for patients with hip and knee pain. You're watching Stronger Together with Dr. Dave.
Said I could play, so any chance to play at all. That's my life. I love music.
Yeah, that's how we do it.
Welcome back to Catholic Health Stronger Together with Dr. Dave. My next guest is Catholic Health orthopedic surgeon, Dr. Jeremy Loloi. He specializes in hip and knee pain and is here with us now in the studio. Dr. Loloi, thank you for coming in.
Thank you for having me, Dr. Dave.
You're a really important guy because how many people watching this show have knee pain or hip pain?
A lot of patients in America. Millions of people are diagnosed with arthritic conditions of the hip and knee every year. So very big portion of our population.
And you have a very gratifying job because your expertise is really replacement. Mm-hmm. So for the most part, when somebody comes to you with knee pain, tell me the sequence of events just briefly.
Absolutely. So it's important to establish a diagnosis with our patients. One of the most common conditions that we treat are hip and knee arthritis. And there are various forms of arthritis, but essentially they all lead to damage to cartilage, which is the cushioning covering our bones and our joints. And the way we diagnose that is we typically start with imaging, such as x-rays. It gives us an idea of how thin the cartilage has become in the joints, how much the bones are affected. Also, it's very important to perform a physical examination on the patients to determine how much pain they have, how much stiffness and limitation to their motion. And after we obtain a diagnosis, we can offer them some treatment options. And we always like to start with the simple things, lifestyle modifications, including some exercise in their lifestyle, physical therapy, sometimes to guide this exercise management, and medications such as anti-inflammatory medications to really bring down the inflammation and joint swelling, which causes such debilitating pain. If those don't work initially, we can move on to slightly more invasive procedures such as injections. There are various types of injections that we use with patients. Predominantly, we use either cortisone injections, which is a strong anti-inflammatory that we inject directly into the joint that's affected. And this can bring down the inflammation and temporarily improve the pain. Other options for injections include gel injections, which we call hyaluronic acid injections. And these are meant as cushioning or lubrication for the joints. And again, can provide some short-term but significant relief for patients.
What percentage would you say, let's not go right to the knee replacement, let's try these other?
I would say I'm a very big proponent of trying everything before a knee replacement. So if a patient has come to me and has tried all those options before and their arthritis is severe and debilitating enough, I think it's fairly reasonable to go straight to hip or knee replacement. But if they haven't really started that process yet, I would always like to try the simple things, the things that have lowest risk, such as the exercises and the medications and potential injections, to see if we can avoid or at least delay surgery.
How long do these injections last for, and how long can somebody stay on this regimen of getting injections?
So it really depends on the patient. The injections are meant for several months. My goal is hopefully about 4 to 6 months at a time, if not more. And some patients I do inject once and I don't see them for a year at a time. Some other patients, unfortunately, don't get as good as a relief from the injections. And injections can last anywhere between 4 to 6 months routinely or longer, depending on the patient.
And then at what point do you say, look, the injections aren't working any longer, we need to move forward with the surgery?
This is the most important discussion I have with patients because I like to tell them, I don't make the decision for surgery for you. Arthritis, although it's very painful and debilitating, is not a life-threatening condition. So it's really dependent on the patient to explain to me when they think they've reached the point of no return for surgery. And typically, it's patients that tell me they're having pain every day, they're unable to live their life to the fullest because of the pain and the debilitation, and they've tried something before surgery. And at that point, I will give them the education for surgery and make the decision with them.
And tell me about knee replacement devices. Are they all the same? Is there a menu of devices that you go over with the patients?
It's very cool technology. It's become through a lot of advancements in the past 20 years and become some of the most effective surgeries in all of medicine, not just in orthopedics. But essentially what we do is we shave down or cut some of the arthritis and cartilage damage, bone damage in the joints, and we replace it with metal and plastic, which the body does not feel. And these implants are highly engineered. They are matched to the patient's anatomy, so each patient's size matches the implants. And they provide smooth surfaces for the joints and for patients to be able to walk on and move on. And they're very durable. They can last upwards of 25 to 30 years.
Realistically, how long does it take for them to get back to playing tennis or exercising or running?
Everyone's a little bit different. We do apply minimally invasive approaches nowadays. and our post-op protocols with pain, with therapy have become much better. So people do progress faster. For hip replacements, I typically see them progressing in about 4 to 6 weeks, 6 to 8 weeks, and they're typically back to most activities. Knee replacements take closer to 10 to 12 weeks. I do advise all my patients that they can see improvements in their function and pain up to 1 year after surgery. So people do get better and better up to a year after surgery. And like I said, the vast majority of our patients are very happy with these surgeries. Most of them tell me they wish they'd done it sooner. And most of them do end up going back to exactly what they want, how they want to live their lives.
It's interesting, you work out of St. Francis Hospital, which we usually associate with heart care, but there's actually excellent orthopedic care there also.
Absolutely. We have a big orthopedic team there performing various orthopedic procedures, including hip and knee replacement, and it's been an excellent place to work, and we provide fantastic care for our patients. It has all the benefits of a tertiary care center, but still has the human touch that you get from smaller community hospitals. It's definitely a great place to work.
Yes, we always speak about, you know, the CHS being a very compassionate system, and I think that's what we try to always do, regardless of what specialty we're dealing with. Is the compassion is always, and the patient is always the center of the care. Well, this was very informative, and we'll definitely have to have you back on the show.
Thank you very much, sir.
Still to come, we've covered several specialties. Now we're going to learn the importance of pain management and the role it plays in the treatment and healing process. That's next on Stronger Together with Dr. Dave.
You can't text and pay attention to the world around you, and you definitely can't text and drive. Every year, deaths due to distracted and negligent driving are increasing. In fact, while drunk driving rates have dropped greatly, negligent driving fatalities have skyrocketed. Find out more at negligentdriving.com.
Welcome back. My fourth and final guest on today's show is Catholic Health Pain Medicine Specialist, Dr. Evan Chernoff. Dr. Chernoff?
How's it going? How are you?
Good, good. Thank you for joining us.
A pleasure.
You are also a very important part of the team because you are a pain medicine specialist.
So a pain medicine specialist is a physician in a specialty of medicine that treats, evaluates, and rehabs people in chronic pain. Chronic pain is a painful condition, usually lasting more than 6 months time frame. I utilize injections, minimally invasive techniques, and as well as injections to help treat patients.
And how do patients get to you? Do they reach out to you directly? Do they come from the primary care physician, the surgeons?
So the patients, they can come out, from basically everywhere: hospital referrals, primary care referrals. Patients don't need a referral to come see me most of the time. It depends if they have, what kind of insurance they have. They can call our office. We can figure out for them if they need a referral, if they don't. If they do need a referral, we can reach out to their primary care physicians. If they don't have a primary care physician, we can always get them into the system with Catholic Health to get them established with the primary care physician here.
So I'm a patient. I come into your office. I'm having back pain. Maybe I have a herniated disc that's not bad enough for surgery, but clearly affecting my quality of life. Tell me your approach to somebody like me who comes into your office.
So again, the first thing would be to evaluate you, see how you're doing, do a physical examination, make sure there's no signs of emergent surgical indications. I would then discuss with you treatment options. So I would do conservative treatment first, working up to more invasive treatment, physical therapy, talking about medication management, possibly injections as well. If these things don't resolve the pain, we can do more minimally invasive techniques. They're not full surgery, but are a little bit more than injections, such as spinal cord stimulators, intraspinous spacers, basivertebral nerve ablations, possibly kyphoplasties as well. These kind of things can help people. They're not a full surgery, but are more minimally invasive and can help people with pain.
So you're really trying to offer the patient two things: better quality of life, and hopefully sparing them from surgery or procedure as long as possible.
Yes, exactly. So, patients that are not surgical candidates, patients that I don't want to go through with a full surgery. That's kind of where my area of expertise lies. Be able to treat these patients effectively with minimally invasive techniques and to restore their quality of life.
Most patients in your practice, they require medicines, pills, and procedures, or do some just do procedures and some just do medicine?
So exactly, it depends on the patient. So some people like taking more medication, some people like doing more procedures and less medication. So a combination of both is actually perfect. You want to treat their pain with medicines, but as well as with interventional treatments and procedures, injections, minimally invasive procedures that we talked about to help them kind of restore their quality of life and get back to how they were living before.
And do they typically come to you after trying physical therapy, or do you find that a lot of these patients are referred to you even before they start physical therapy?
So it varies. Again, depends on who refers. Sometimes the surgeon will refer to me. They've usually gone through the gauntlet of physical therapy already, and they want to try more minimally invasive techniques. People that are referred from primary care physicians or from the community that come to see me, they usually start from zero. So we start with physical therapy, imaging, discuss medications, and kind of go from there.
You're part of this team, so you're speaking with the surgeons and you're speaking with the other team members to make sure that the patients are getting very personalized, individualized care.
We work together with other specialties such as spine surgery, neurosurgery, orthopedic surgery, and with the primary cares and other specialties to create a comprehensive treatment for patients that includes both medications, minimally invasive procedures, and injections.
How do patients reach out to you? How do they find you? If they're in pain and they need your services, what's the best way to get in touch with you?
So the best way to get in touch with me is through my office. Additionally, if you need a referral, we can work through the office to call your primary care physician, get the referral for you. Also, if you don't have a primary care physician, like mentioned before, we can always get you into the system of Catholic Health to get you a primary care referral.
How long do you wait to say to a patient, look, your back pain, may go away on its own? Or is that not even an issue because by the time they get to you, they've had back pain or severe pain for quite some time?
So again, it just depends on the patient and their pathology. Sometimes a herniated disc will resolve on its own, sometimes it won't. It will require surgery. And that's kind of the area that we lie in the middle of pain management. So we do the injections, the medications, the minimally invasive procedures to kind of help people realize their best potential to get the maximum pain management that we can for them. And if that is unsuccessful, then move on to surgery.
Gotcha. And it really sounds like what you're saying is there's really no cookbook, approach. There's no real clear algorithm. It's really very individualistic and patient specific.
Exactly. And that's how I treat all my patients, individualized treatment. A cookie cutter doesn't fit everybody. This problem may not be good for one person, but maybe a fix for the other person. So it just really depends on the person and the pathology that they have.
Right, that's excellent. And that's a great way to end this conversation. So I hope to have you back on the show. Thank you for taking time out of your busy schedule.
No problem. It was a pleasure.
Thank you, Dr. Chernoff, and to all my guests for such a great show. As you learned today, although back, hip, and knee pain is common, there are plenty of talented specialists with great treatment options available across Catholic Health. If you would like to know more about Catholic Health or to make a gift in support of one of the amazing programs you heard about today, please visit chsli.org or call 1-855-CHS-4500. Thank you for watching today. I am Dr. Dave Degatti, and I'll see you next time on Catholic Health, Stronger Together with Dr. Dave.